Welcome everybody tonight. My name is Vince Ligori, and I want to welcome everybody to tonight's webinar, The Future of ED Therapies with Dr. Richard Gaines. Before we get started, I want to point out how we're going to run this webinar because there was a big response to this first webinar. And at this point, we had over 200 people register. I don't know how many people are on this call right now. There's a lot. So we're going to start by asking everybody that we want as many questions as you can send us. If we can't answer them tonight, we're going to answer them all back in the next day or so. For that reason, we have everybody muted because there's a lot of people on here. If everybody starts asking questions at the same time, we won't have a successful presentation. We want all the questions emailed to this email here. I'm monitoring it and I'll read them. So it's Gaines Store. There's two S's in there. Gaines Store, STORE @gmail.com. If everybody could, take a moment, write that down, put it in your email browser. Brock, if you could keep this all open while I introduce Dr. Gaines, that would be great. So everybody has enough time to make sure they have that email. So we're doing this instead of the chat tool. There's a couple reasons why. One, we've had some doctors want to ask questions, and they don't want their name associated to 80 people on a webinar or 100 or how many people are on here. So it's an easier way of doing it. It's cleaner, and some people have problems using webinar tools. People use multiple webinar systems, and they're used to GoToMeeting, and this is JoinMe, or they're used to Zoom or whatever, and they can't find the tool. This way, everybody can use the simple email, and then we'll also have a record so we can respond to questions that we can't get to or require a little more research to answer. So I'm going to go over Dr. Gaines and introduce him a little. So Dr. Gaines, for many of you that don't know, Dr. Gaines is a known commodity, if you don't know who he is. For those of you who don't know who he is, Dr. Gaines is the biggest name in ED, or erectile dysfunction therapy. Dr. Gaines pioneered a type of ED therapy, which is also bears his name, and for contractual reasons, we can't name the product or Dr. Gaines' name or in association with that product, because he has now divested from that company, but they do still use his name. And so, unlike the NBA, there's not really an argument, there in ED, but in the NBA, we argue is Michael Jordan, Kobe Bryant, LeBron James is the biggest name. Well, when it comes to erectile dysfunction, there is Richard Gaines. There's not a Peyton Manning or a Tom Brady to argue about. Richard Gaines is, and his protocols are the biggest name in erectile dysfunction. I don't know a lot of people or doctors out there that would have, they would even argue that. So the Dr. Gaines was instrumental in helping, produce his first, or actually we want to thank, there's a few doctors on this call possibly, and scientists that helped Dr. Gaines, pioneer his first ED protocol and patent. For those of those doctors or scientists on this call, we want to thank them, and probably Dr. Gaines is going to reach out to you in the near future and ask your opinions. So I just want to tell everybody a little bit about Dr. Gaines. Besides the obvious inventor and pioneer of an ED therapy, which a lot of people know what the name of that is on this call, Dr. Gaines was a anesthesiologist for over 2 decades, I believe 21 years. And he was Harvard and Tufts educated. I think he went to University of Boston. If I'm wrong, you can correct me. And, he likes, when he's bored, he goes hand gliding. He's also licensed in 26 states, I believe, still, because he had the big anesthesiology company. And right, Richard? You had a
yeah. I was required to have licenses because I set up various departments of anesthesia across the country for what's now a very large company. I divested of that also. So, I started age management early 2004, but I was always interested in age management medicine or anti-aging medicine.
Can I ask a quick question before you get started? Ladies and gentlemen, I'd like to introduce you to Dr. Richard Gaines. And for the first question, I want to pose it because I've known Dr. Gaines for a long time, and I don't think I've ever asked him this. How did you actually, get into this ED and sexual wellness business?
Yeah, we never talked about that, Vince. It's very interesting. I mean, I can tell a good story about that because, when I started this anti-aging medicine, I was very interested in helping people's, improve their health and longevity and maintain their age. So people came to me, and over the years, most of the goals of my patients were, body composition. They didn't want to be fat. They wanted to be more lean and fit. Cognition, thought processing, and sense of wellness. And number 3, energy levels. They wanted good energy levels. Well, if you go down to number 4 and 5 and 6, number 4 was increase in sexual energy, and this was true for males and females. So I did, of course, I did my due diligence and learned everything about, body composition and energy and cognition and what we need to do to maintain that. And sexual energy, being what it was not. I wasn't satisfied with much of what's going on because the medications that were put out in the mid '90s, of course, like Cialis, Viagra, Tadalafil, Sildenafil, these were designed to basically increase pelvic blood flow in a sort of, I have to say, not in an unnatural way because it's not naturally increased because the blood vessels are deteriorating. So basically, it's just putting a Band-Aid on the problem, like a lot of other drugs. And I looked into what was available around the world, and this is technology that is nothing I invented. In 2010, they were already doing studies for erectile dysfunction. There's over 50 studies now, and many of them are double-blinded, randomized, sham-controlled studies showing that this technology works. And we'll get into that a little bit later. Because I know that on this call there are going to be some newbies to this type of shockwave therapy and erectile dysfunction, and people who are experienced and people who have actually, as you mentioned, have actually helped me develop this initial product. I have something much better than anything on the market now. I had been meaning to introduce it years ago, but I finally got this. I did get a patent on this pending. And I'd like to bring it out and show everybody what it is. And I'm going to introduce it today. So,
all right, that's great.
Yeah. Oh, yeah.
So what I gather before you move on, before you tell the story, is that you didn't just leave anesthesiology and then specialize in penises. You it's
no,
kind of
I wasn't ever. It's not that I was totally interested in sexual health my whole career, but it's one of the. It's very high on the list for most people. The funny story I was going to tell you is that we were doing a lot of advertising for the product I was making and my company in the years past. My mother passed. She was 90. She did very well, but just before she passed, she looks up at me and says, "Richard, I hear a lot of ads." And my mother was a vice president of an oil company. She's a very formal type lady. She goes, Richard, I've heard a lot of ads for erectile dysfunction. Is that you? And I said, well, Mom, yeah, that's the company. She means, are you a dick doctor? And I was taken aback, and I didn't know what to say. And she was very serious. Are you a dick doctor? And I'll always remember that because she was a very formal type of lady and a little bit of a Puritan, so it was an interesting moment. But if we can move on, I'll actually go to the first slide, and these are actually slides I threw together just to sort of keep me on track, and I'll breeze through a lot of these without maybe completing everything on the slides. But the shockwave therapy has been around for a while, and the next slide will show you that in World War II, the Germans noticed that sailors who were submerged and exposed to depth charges would float up to the top and are dead. They took them and they opened them up, and their lungs and liver and spleens were all blown up. So they thought this was going to be this type of blast or pressure wave was going to be very useful in the military for military means, and the German government put a lot of money into it. As it turned out, they were the first to really design, and this is after many years in research. They were the first to design an adequate lithotripter, which is actually now the gold standard to dissolve kidney stones. This is a sound wave that is focused within the body, below the skin, into the body, onto a kidney stone. It fractionates the kidney stone, and it is passed through the urine. Now it's now the gold standard for appropriately placed kidney stones. Of course, at that time also they noticed that people were waking up and their back pain was gone too. Not only were the kidney stones gone, but they were sort of free of back pain and other maladies. And these a lot of people were interested in this. Orthopedic surgeons got a hold of this, and they realized that it is actually good for musculoskeletal issues, bone health, and now it's FDA approved for lateral epicondylitis and plantar fasciitis in this country. The International Society of Medical Shockwave Therapy came about in the mid-'90s, and in '97 it became international. These guys have meetings every year, and they go over all the uses of shockwave therapy, and you would be amazed at how many things that are offered. I mean, all the way down to coronary arteries. You can actually clear up coronary arteries with focused shockwave therapy. Of course, you slave to the EKG, and they make sure that there's no RMT phenomenon, but it seems to work for increasing blood flow to the myocardium, and it's documented. This is all documented, and actually in humans as well. So ED actually was first studied in about 2010, and the credit really goes to an Israeli group, Vardan and his people, Grunwald. They did a lot of research, and over the years they did double-blinded randomized control studies, which showed very positive effects. Next slide. Now a lot of research is done throughout the world, and there's a lot of research coming out of Denmark and Japan and China and Turkey actually, and I put this slide there because extracorporeal shockwave therapy goes by a lot of different names. And ever since the product was introduced, there are a lot of different names: acoustic pulse therapy, electrocorporeal pulse-activated therapy, low-intensity pulse ultrasound. But these are all terms that actually, some of them don't even make sense, but it's just for sales. And, shockwave, extracorporeal shockwave therapy isn't the best language for this type of thing. But that's exactly what it is in technology terms. Next slide. So we're going to talk about the prevalence of erectile dysfunction, and of course, mostly we're going to talk about males on this particular talk, but females have their own odds. As a matter of fact, in males, it's very simple to go look at the levels of erectile dysfunction, either moderate, minimal, or complete. And at age 50, 50% of men, generally 50% of men have some form of erectile dysfunction. At 40%, at 60%, at 70%. It just keeps on going up. And the reason is, there's a lot of reasons, but one of the reasons is, I think, it is blood flow. Vasculogenic ED is probably the most important reason for erectile dysfunction. Of course, hormone levels and toxins in the environment and thought processing, of course, are very important as well. But most erectile dysfunction is attributed to vasculogenic reasons. As a matter of fact, if anyone has seen the human body exhibit, these were Chinese prisoners, I don't know, but these guys were dissolved, and basically different layers of their tissue remain. And you can see there's ones with bones, just only bones, only with the nervous system, only with the veins, only with the arteries. It's amazing how they did this, and they positioned them in different positions. I don't know. I was very impressed with that exhibit. One of the exhibits shows the arterial system, And the arterial
Oh,
system.
wait. Are you talking about the human body exhibit in Las Vegas?
Yes. Well, they have it in most big cities now. It used to travel across the
Okay.
country. It started. The first one was in New York. This is years ago, and now they have them established because there's more and more dissolved prisoners. I don't know where they came from, but that's what I think. But these arteries actually end in cotton candy-like capillary beds. And if you look at one of these, there's a lot of cotton candy in the perineum and in the penile area. What happens over the years is this cotton candy deteriorates, and blood flow decreases. Drugs like Cialis and Viagra will force blood through the remaining atherosclerotic blood vessels and helps erectile quality. The key is, why don't we just grow these things back? And that's what we know happens with extracorporeal shockwave therapy. Next slide. I guess, let's see, I just put this with women. This is women, and generally it's about 40 to 50% in women in general. And women are much more complicated because they have all sorts of issues with different phases of the sexual response. So it requires.
So when you say 40 or 50%, does that mean that like 40 or 50% experience something similar to erectile dysfunction or to sexual dysfunction?
Sexual dysfunction, because basically, men can have issues with the desire, arousal, orgasm as well. But it's fairly obvious for men to know that they have ED or not, because it's either there or not there. Women can sort of fake it, and they're not included in the data. But we think that all cause is about 45%, and it's probably going up a little bit. And these actually are in young women and old women. We're talking about across the board. So that it does exist, and there are therapies for women specifically. And I think that shockwave therapy may be appropriate also for women. Next slide. Well, a good sexual energy there's a lot of good reasons why we need it. And we know it's associated with decreased stress and ulcers and depression. There's less heart disease. There's less incidence of cancer. I mean, it's crazy. But if you think about it, it makes sense. What comes first? Either no cancer and good sex, or good sex and no cancer. The thing is, the bottom line is that it's associated with good things. So maintaining sexual energy is very important going forward, even as you get into the 70s, 80s, 90s, wherever it is. And we know that these things that you're looking at are definitely associated with good sexual energy. Next. Newer therapies. There's a lot of therapies. Of course, there's herbals and constriction devices and vacuum devices for men. For women, there's some vibratory devices and heating devices, all sorts of different things. But the newer things we're talking about is a P-shot, no-shot, with and without exosomes. Of course, stem cell therapy is exciting, but I believe that exosomes are going to be the way to go. They have very little DNA, if any, from these pure stem cells, and they're collected from the stem cells and put on a shelf. They can be stressed for different issues. And so it can be different exosomes eventually will be used for different reasons. So I see that coming really, really soon if the FDA doesn't get in our way. But I've seen some very good things with exosomes. Vaginal rejuvenation is getting very popular. Radio frequency and laser are the most popular right now, and I've seen some good results. We have a piece of equipment here that the women really do like. The good thing is about this one piece of equipment is you can use it on the face as well, because it's a sort of like it works like a fractionated laser, so it's a very good device.
So I just got a text question from one of our team. So just go back to exosomes and the P-shot. I know you're going to probably introduce a little later, but somebody's asking about Wharton's jelly because it has super high concentrations of exosomes plus the Wharton's jelly and other things.
The Wharton's jelly is actually coming up here, and I have some experience with it. I'm trying to get more experience. As a matter of fact, I have an IRV to use Wharton's jelly and with and without shockwave therapy to treat erectile dysfunction. So that is going to be coming out. We're going to start that study very shortly, and I assume that Wharton's jelly is going to be very effective, maybe more effective than I've had with exosomes, because they are concentrated. It also has hyaluronic acid in it, which is of course a natural substance, which creates a scaffolding for the exosomes. Exosomes are so small; they're 50 nanometers. They're so small you can inject them. If you inject them anywhere and just leave them there, they'll be washed out in 10 minutes. You have to put them.
Okay, so I don't want to go out of order, but I got another question that's right on that.
Yeah.
Will the hyaluronic acid also kind of stick around and increase the volume of the penis?
Well, yeah, actually, that's probably true because we know.
But you haven't tried it yet.
Well, I have, because I've had.
Oh, okay, gotcha.
Because I learn a lot from my patients, so they demanded that I inject some hyaluronic acid. Hyaluronic acid, which is Juvederma voluma, into their corpus, and they get a lot more fullness, and they feel better, and they come back after a year and insist on doing it again. It has not caused any problems. It's a natural substance that gradually gets resorbed into the body. So it does create fullness, and I would assume that Wharton's jelly would do the same thing. I'm looking forward to that. By the way, Wharton's jelly injecting in joints, I think is going to be incredibly good because it already has scaffolding, keep in mind. And you inject the exosomes. And what I usually do is, for the P-shot, no-shot, of course, you're using PRP as the scaffolding for the exosomes. But with Wharton's jelly, you don't really need the PRP, and you can just inject Wharton's jelly by itself. There are two drugs that were introduced for female sexual health. Fenbanserin was a big failure, as you know, Adivia or Adii. That actually is an SSRI that was supposed to help female desire. It really hasn't worked, and so it sort of faded out, unfortunately, because people thought it was going to be great. PT141, everyone out there might know, because peptide therapy is very, very popular now. I've been using PT141 in my patients for about 8 years. It is a peptide which is a melanocortin. Melanocortin actually is a hormone, basically, but when it's given as exogenously, it can create tanning, and it was thought to be useful for those who can't tan and are sensitive to the sun. So they started a trial with giving this to people, and they got tan, but they also got very horny. So they actually looked at it, and the scientists cut down the molecule into something called PT141, and it doesn't cause that tanning, but it does increase desire. So it works centrally on areas of the brain, and it seems to work for a good amount of patients. There's one side effect which is not very pleasant, and it's a bit of queasiness that occurs for about 20 minutes in 10% of patients. But it does last for 1 or 2 days, and it just really works on desire. For men, it does help erectile dysfunction as well. So I make it clear that it's available for my patients if they continue to have issues. The FDA name for it is Vyleesi. It's out there. So it was only FDA approved about 3 months ago. And of course, shockwave therapy is new, is probably the newest. Well, no, PT141 is the newest. But shockwave therapy is going to be very, very useful for many different things in this country at some point. We're a little slow to catch on. We know it works well for erectile dysfunction, and I happen to know it works well for female sexual dysfunction as well. Next slide. Okay, shockwave therapy. I'm not going to get into theory too much, but basically a shockwave is it's different than a sound wave. A sound wave has a biphasic appearance. It's a sine wave, or sound wave is like an S. There's positive side and a negative side, so it's a sine wave. As far as shockwave goes, it's more of a blast. It actually has a positive deflection, very little negative deflection. And it does these. This is a real major difference because the cells in your body respond differently to a blast as opposed to ultrasound or a biphasic sine wave. Next. By the way, shock waves are actually faster than the speed of sound. That's why I was showing you that picture of the jet breaking the sound barrier. And thunder is also as a result of a shock wave, and blasts are also a result of a shock wave. Biological effects that shock wave causes on cells. Next. Just our cells live in an environment, and we're just disturbing their environment a little bit without doing too much damage. But now what happens is basically they secrete growth factors. They enhance the effect of the resident stem cells, and actually stem cells are signaled to come to the region. So for repair or for whatever they think is going on, and it's these are a lot of the biological effects. It's anti-inflammatory. Accessodyne means it actually creates, through gating theory, it creates some pain relief. There's transduction, proliferation, differentiation of a cell through the cell cycle. And as you can see, stem cells actually will listen to this also. Next slide. Oh, there's a picture. Okay, I put it in there. That is from the Human Body Museum. This is a young person, obviously. Their arteries are pretty good, and their capillary beds are very good. And you can see the pelvis shows a lot of these cotton-like capillaries, which carry a lot of information. As a matter of fact, there's in stem cell therapy and stem cell science, a lot of these stem cells actually exist as parasites. It's called pericytes, P-E-R-I, over these capillaries. So if they're stimulated with shockwave therapy, that's why neovascularization is one of the major results of shockwave therapy. Next. A lot of studies. I picked out this one because this was the first study done in the United States. The United States is not really quick to accept these things. In Europe, it's already accepted, and they've been doing it since 2015 or so. In 2017, all the studies were accumulated that had been done, double-blinded, randomized controlled studies, a total of 600 patients. And the study was conducted here at the Department of Urology, California, Baylor, and University of Miami. I'm friendly with Dr. Ramasamy, who represents the University of Miami. He's now in phase 3 studies, and I'll tell you about that later. But this study he did shows the conclusion is very clear. It resulted in significant increase in International Index scores, or SHIM score, for men with ED. Very clear.
So this says shock wave, so this is probably focused wave?
Yeah, this is focused. As a matter of fact, all 40 or 50 studies done in Europe, in other countries, were done with focused wave.
But this one is the USA.
Yeah, the product that I introduced, I will talk about it later, but I introduced a product that was less difficult to use and more, let's put it this way, it's a medical class 1 device, so a secretary can even use it, or you can write a prescription for your patients if they can afford $20,000 for the machine. It was a radial shockwave device. Radial shockwave have very few studies supporting its use for erectile dysfunction. One just came out from Turkey, and it seems to work, and it worked for me. That's why we went forward with it, and we were very pleased with the results. But again, know that all the studies in the literature, all 50, were done with focused shockwave, and all these studies done in this meta-analysis were focused shockwave, which is a medical class 3 device. A nurse or a doctor have to be present when it's being used. Next slide. Well, this is an interesting thing. I put all the interesting slides together because this is a transection of a penis. Yes, it's a rat penis because you can see it doesn't look. If you remember the anatomy of human penis, it doesn't really look like this. But this is a rat penis, and hundreds of them were sacrificed at the University of San Francisco. What they did is, if you look at the top row, there's young and old. There's young and old penises. They were transected before receiving any shockwave therapy. You can see there are a few stem cells because they used a radio-tagged DNA segment protein that was incorporated into stem cells. So they can see the progenitor stem cells in the young and the old. When they did shockwave therapy, a day later, they immediately transected the penises of those rats, and you can see there are many more stem cells which are present. And these stem cells do what they need to do. They either create new vessels, they repair tissue, and most of them will, if they're residing, they mostly reside under the tunica albuginea in the penis. But you can see the numbers are much increased after exposure.
What was that? What was that word again?
Which word?
They reside under.
Oh, the tunica albuginea. The tunica albuginea is a layer of tissue surrounding the two tubes in the penis, which create the pressure, contributes to the pressure for an erection. So that's a very, very important layer of tissue that I think is affected in a positive way with acoustic wave therapy or shockwave therapy. Next slide. Okay, this is the differences between focused and extracorporeal radial pulse. Radial shockwave therapy is not really shockwave therapy. It's mostly a biphasic wave. It is more on the positive side, but it is a biphasic wave. The upper handle is a radial pulse generator. When it's applied on the skin, it actually gives most of its energy to the surface of the skin. It loses energy and diffuses outwards as it enters the skin. It is effective. I've used it in the product that I developed years ago, and it does work fairly good. But all the studies, again, were done with the device below. Below is a focused shockwave handpiece. The forces, the sound waves are reflected off a parabolic mirror, which actually focuses 4 or 5 centimeters in front of the handpiece. That clear piece, that clear cone you see on the end, is called a standoff. You can make the standoff as long or short as you want because you can vary the depth of the energy spot, and it's much more accurate. The energy is delivered below the skin. There's no energy to the surface, and it is much more precise. I happen to think they both have some merit, so I combine the use of both of these waves. And I know that radial pulse works. When I've added the focused, it works a lot better. And that's what I have now. It's a product called DualStim. I've actually patented it, as I've said, and we are doing studies. Next slide.
So one of the, before we move on, Richard, one of the things that happens is that with the focused wave, you don't necessarily need anesthesia when you're working in that area, because the other, I've used the other equipment on my feet, and it pounds.
Correct.
So it vibrates.
Correct. I mean,
the focused wave does not.
Honestly, it's in the hand of the beholder, actually, because I can tell you that I never use topical cream, and people are going to be surprised about that because I taught many doctors to use it, and really I taught that because I want them to make the experience more pleasant for the patient. What happens with shockwave therapy, as I mentioned before, there is a Cessadine effect. Gating theory is such that if you tap a local area on your body 1,000 times, it sort of gets a little numb to the taps. So this is what I use instead of the cream. I actually use the focus wave first, which creates basically anesthesia along the, I don't want to say, it's not deep anesthesia, but it creates a more of acceptance. It creates some sort of anesthesia so that when I apply the radial, there is nobody complains about it. So I don't like numbing cream. I have it here for those patients who are very sensitive. I haven't used it for 6 months now. And if I do use it, it gets on everybody's hands, on their lips, and then you walk out of here numb. So it takes about 2-3 hours for it to wear off. And it gets on their underwear. They're numb all day long. I don't like it. So I don't use it, but I don't necessarily discourage the use of it, because if the technician isn't savvy enough to go up slowly on the millijoules or bar, then the patient may have a bad experience. So I don't discourage it, but it would be good for everyone to learn how to go up gradually on the energy levels where they don't need to use the numbing cream. Next slide. Okay, this is a slide of a real shock wave. As you can see, it goes up very quickly. It's 1 microsecond. The whole thing lasts about 10 microseconds, but you can see it's a very sharp uprise. And a blast looks like this too. A bomb looks like this. It just goes up quick, and then there's a decay, and it does dip below, creating a little negative pressure, and cavitation results, which is a good thing from this negative pressure. But generally, it's mostly a positive wave. The cellular environment is affected by this type of wave, and good things happen. Now, I want to show you the difference between this wave, the focused wave, which we're looking at right now. This is focused, and the next slide is the radial wave. The radial wave is much different. Next slide. You can see the look at the radial wave is different. It's still about, the whole thing lasts about 20 milliseconds. It's twice as long, microseconds. It's twice as long, and the upslope isn't as quick, but it does get that positive, the positive side of things. But you can see the negative, how it floats around down there. It's a totally different looking wave than any of the studies that were done on shockwave therapy for erectile dysfunction. Again, there are a few studies showing the benefits of radial. I don't want to tell anyone it's terrible. It actually does work, but I know focused has been proven to be better, and the combination of both is best. Next slide. Again, this is another cartoon of the focused, which is on the left, and radial, which is on the right. And you can see the corresponding waves. Next slide. Okay, these are some studies I guess I was going to show you here. This is another meta-analysis. I think it's more recent. This study is it's 2017. So it's basically done by Dr. Liu. This is just a number of other people in China doing the same study that was done here in the United States, showing the benefits. Next slide. This looks like it's a Chinese study that I picked up. It's actually was earlier this year, and they did another meta-analysis between now. They collected data through June of 2018, and the bottom line is it's significant improvement. There was significant improvement in a total of 522 patients. Next slide.
It does. Listen, so it says 522 patients. Does that mean in all 522 patients?
Yeah, it means they chose probably 14 or so studies, and in those studies they accumulated 522 lives that they followed, which is a lot, because most of these studies are small studies. There are 100 people. There's maybe 200 people, and they put them all together. This is a homolog of external genitalia. This is an embryo on the top there. And the reason I show you this, it's an interesting thing that I really believe in. You can see the yellow dot there is the genital tubercle, and this is early on in embryological development. As pregnancy goes forward, of course, influence of hormones, and things are going on. And on the left lower, you can see that there's an anus. You can see the genitals, the tubercle, and there's something called a median raphe, which is down from the anus, and it's that pink thing, the pink band, and that band zips up all the way to the genital tubercle, which becomes the glands and the urethra, that's a male. That's what a male is. In a female, on the right, it doesn't zip up all the way. The median raphe is left open, and a female will develop. So you can see the tissues are actually very similar, and I can go further and tell you the similarities between them all. But in basically what I try to show here is that men and women, the anatomy has very similar qualities. As a matter of fact, women, one of the things that a lot of the women complain about is vaginal lubrication, and lubrication is an ultrafiltrate of blood flow. So if they have good blood flow, their lubrication will be maintained, and that's one of the big issues with postmenopausal women, that their vaginal mucosa becomes atrophic, and they have dryness and some pain. So keeping everything with good capillaries, keeping the capillary good cotton candy, will actually treat the problem instead of medications. Next slide. These are adults on the next slide. Oh yeah, so that's a male, that's a female, and you can see the homologs here. You can see that the vulva are actually parts of the what would be scrotum in the male. Next slide. These are adults. Of course, on the right is a male. It's composed of 3 tubes. 2 of the tubes are corpus cavernosum, and the spongiosum is where the urethra goes through and through the head. So that's the male. It has crura that extend down into the pubis symphysis. The female has a clitoris with crura as well that extend down on the lateral portion of the vaginal opening under the vulva. And I can tell you that they have very similar erectile qualities. If you transect the clitoris like they did for the male rats, you would see 2 tubes instead of 3, because the urethra comes out in a different location there, and it's not within the corpus. But these tissues are the same. And this is the slide I think I ended on, because I just wanted to make it clear that I'd love to do some studies, and I did a small study in my past business. I did a small study on females. We had 10 females, and only one of them dropped out. Most of them had good results. One dropped out because she got pregnant. So it might be a good thing, and I think it would be. I think it does. I'm sure it does work for women too. I got to put a study together for that. And I think that's it. We'll take some questions. So what's the next slide? Are we done? Oh, here it is. Okay, questions.
So I got a few questions lined up here. So
okay.
One is, where do you inject the PRP?
Well, PRP, the P shot is something that Dr. Reynolds developed and patented the name a while ago.
So some people don't know who Charles Reynolds is, the inventor of the brand name Vampire Facelift and Train. Correct? Right.
Yep, P-shot, Vampire Facelift, and O-shot, and a couple other things that he said on breast lift and everything. But they very cleverly used PRP. PRP is nothing he invented. It was used before, but not for those reasons. He took it upon himself to try that, and it seems to work. It does work to rejuvenate blood vessels, because what you do is you take a patient's blood, you spin it in a special centrifuge a few times, and you get growth factors which exist in the platelets. Those are injected back into a region where you want to stimulate rejuvenation, and it seems to work. We know it works on the face, it works for hair, it works for joints, and it works for genitals. So we can inject the P shot is injected in the corpus cavernosum on both sides, so there's 2 corpus cavernosi, and in the glands. So all the erectile tissue of the penis, there are 3 tubes. 2 of the tubes really contribute to the erection. The spongiosum, where the urethra goes, and the head is part of that, doesn't have a tough layer around it called the tunica albuginea, so it doesn't contribute that much to the erection, but it is erectile. It does increase in size because of blood flow. So we inject all those three tubes in men.
So you do 3 injections.
We do actually what the P-shot. I've been ordained as an instructor. What we recommend is two shots in each cavernosum on the right and left side, and then 1 shot into the head of the penis, which is the spongiosum. Now, a lot of people are using, of course, BLT cream for this because it's a bit uncomfortable, especially the head of the penis. But in my experience, and I started introducing this a long time ago, is injecting the dorsal penile nerves, which lay in a certain anatomical position, which is basically very easy to anesthetize with 2 cc's of 2% plain lidocaine. So 2 cc on each side, and the whole penis becomes numb. So it's a much more pleasant experience. Most of my patients talk right through it, and I'm done before they know it. I got another question that's related to this question. So you definitely train people and cover this because the doctor says he'd be nervous to inject somebody and have them punch him in the face. No,
the question is.
In my course, I don't blame them. You should be. I mean, you got to know the anatomy very carefully. It's not that difficult, though. I do go over it thoroughly. We talk about the nervous system, the anatomy in detail, and the different layers of tissue that you'll be entering with a needle. So it's very safe, very safe. Even if you inject the local, let's say you inject the local anesthetic into an artery, the dorsal penile artery. Well, the local anesthetic is, the milligram percentage is, the most you're going to get is 40 milligrams or even 100 milligrams into an artery. It's not going to do anything.
Okay, so one more question related to this, and I'm gonna change it around a little because it's probably something I can't ask. With regards to the old patent methodology with your name associated to it, did you teach this technique in that training?
The technique where I
inject the penis, right?
That's where I introduced it, and it's a very common procedure now. As a matter of fact, they are doing it in a similar fashion in females. The anatomy is a bit different, but they can get good results because the clitoris is very sensitive. It has the most concentrated number of nerve endings in the female body, so it's very unpleasant if it's not done. So the injection, I recommend that injection as well. So I do teach those.
So I'm going to speed through some of these questions, Richard, because all of a sudden I have a bunch of them.
All right, I'll try to answer them.
Can we get copies of the double-blinded studies? So I guess we could, I could answer that. If you send them to us, we could create at the end of this, if people registered, we could create a library archive of them and start sending them to people, maybe, right?
Yeah. Oh, sure. Yeah. Absolutely.
So this is one. What do you charge a patient typically? It's a tough one, right?
Oh, that's a good question. And, I've designed my practice so that I have nothing to do with the costs of things. I give everything away. So I've to take care of all that for them. But in general, we know that a P-shot is going for between $1,600 and $1,900.
Wow.
Exosomes, of course, yeah. When you add exosomes, it goes up exponentially. It's coming down over the years because there's so much competition and people are calling it by different names. So you can find somebody doing it for $1,200.
And I see a lot of people selling jeans, or I won't use the name, selling. Yeah, I guess I can say it. You can't, but selling those procedures in packs of 6 for $3,000. I mean, there's a radio commercial by where I live every 5 minutes, mentioning the name of the company and the.
That's what used to be recommended. I believe that's coming down in price now in general because of all the.
So, but the $500 for a 20-minute treatment is not bad money.
Yeah.
Even if it's $300, it's not horrible.
It's great, and because it really does work, and people appreciate they appreciate help for sure. It's very frustrating.
Here's another one related to that. I'm sorry to rush you along here, but do people come back for yearly maintenance?
Oh, that's a really
after they've
question.
completed the program is the question.
Yeah, there is some good studies showing that this may last for a year to 18 months. What happens is the aging process does continue, but of course, if you're healthier, it would you'd be better off. You'd probably last a year and a half without having to repeat this. Well, people come back for tune-up. We see it happening now. People have bought a year's worth, and they come back every 4 months for a tune-up.
Well, that's great because then you got the patients coming back. You can sell them. I mean, that's one of the big problems modern doctors have right now is the reimbursements are low. And now you've got a reason, after this, you've got the patients coming back, even if you had a reduced rate, they're coming back for like a tune-up every quarter. It's kind of the same reason why I like hormone pellets and other things. They got to come back, right?
You got it. And the beautiful thing is you can introduce them to other things and tell them what's out there. I do not.
Tell them that ABC pill, right? Like.
Yeah.
Okay, so how many arteries are in the penis? I mean, I'm pretty sure I can answer this one, but I got an argument the other day, so you can answer this argument for me. Some people say there's 3, and I was told there's 2 in a vein. Why don't you answer this? You're the expert. How many arteries are in the penis?
There's 4, because there's
There's 4 arteries in the penis. Okay, we both got it wrong.
The dorsal penile vein artery. There are basically 2. If you look at it comes from the pudendal and then the perineal, which branches off into on 2 sides. So there are the central artery or the cavernosal artery are 2 in number, and the dorsal penile is 2 in number as well.
So it's funny about this. I almost draw an analogy. It's almost like a little umbilical cord.
Oh yeah. Well,
I mean, it helps create life, right?
Different. Yeah, no, it's different though. It's different.
Yeah, I know. I got you.
The veins. I didn't even discuss veins. Veins are an amorphic structural thing, and there's they've named 5 or 6 veins. So
there's 5 or 6 veins in the penis and 4 arteries.
Yes, and they coalesce. The veins coalesce into complexes, but the arteries are more.
So basically, I won't name the doctor, but nobody's going to win that $1 bet. I guess that's a draw. So do you think that plaque-causing blood flow in women, you might have already covered this, can be cured as effectively in women as men? Kind of tough to figure it out because getting the data on women is tougher, right?
No, that's a very good question. I can tell you that women are humans also, and their capillary beds do deteriorate. So I can unequivocally, I can actually say yes. I can improve their capillary blood flow and their neovascularization with the application of this type of therapy. And
so there's a Wharton's-Jelly question that popped up too. I mean, are you able to release this out? Are you using a full cc of Wharton's jelly, or what's a protocol, or do they just have to wait?
They have concentrated Wharton's jelly, so it can be very concentrated, and you know how many trillion can be in 1 cc. So 1 cc sometimes can suffice. Yes.
Okay. Well, 1 cc, seems like could be a lot. So when is training available?
Well, we're putting this together. It should be available in towards the end of November, and we can make anybody who's interested aware. We have a fun time when we do this, and I enjoy it. And there's a lot of other things that we haven't talked about that I trained as well. So
one of the another question popped up here, and I'll field it. Do you recommend certain products? And on this call, if you want, certain products that Richard uses, or we send it, register, and we'll be able to get back to you with that. But we're trying to make this call informational. But there are some preferred products that you probably use in your practice, right?
Yes, I do. Yeah.
I know you like to use name brand hyaluronic acid, and that,
Exactly. I do. I vet my vendors, so I do know. I make sure that the PhDs are very dedicated and they have a good pedigree, and that their labs are up to snuff. There are a lot of places out there now, so I recommend even compounding pharmacies. I go and I look at them and I discuss their.
So you're even looking at like things like third-party testing, and I mean, you got to be careful now, right?
Yeah, and you have to be careful. You have to know the pedigree of well, for medications, for instance, where they obtain them, how are they testing each batch, and for biologics, it's even more important about all the infectious agents that need to be tested. And
I've got another question. I think I'm going to field, and we'll make it the last question of the night.
All right.
Brock, while I'm doing this, could you put up the registration for more information page and where to go? But I've got like 4 asking how they can set up a meeting with Dr. Gaines in various ways, talk to Dr. Gaines. We're going to be in the process of setting up some sort of schedule where Dr. Gaines can actually talk to people. He also has a busy practice as well, so that is coming in the near future. Hopefully in the next 2 weeks we'll have that set up.
Yeah, we'll fit it in.
And
yeah, we'll fit it in. I'll make some time this next week. I haven't set time aside, but I'll just make it happen.
Right. Because the problem we've had is when people want to reach out to you, some doctors have to understand that they're trying to reach out to you, and they're trying to get you to fit to their schedule instead of
it's very hard.
Them accommodating your schedule, and it's tough, right?
We're all very busy. That's true.
Yeah. So if we had a couple set times a week, and it may not happen next week, but in the near future, that the doctors could access you, that would be great, even if it's a couple hours a week. But this way, people could schedule around their schedules everybody could try to accommodate each other. Anyway, I want to thank you so much. As usual, I learned something.
Yeah.
The questions were fantastic, and we have recorded this, so we're also gonna make it available to all the participants so that you can review it, because you covered a lot more information than I thought you would have, or I learned a few things myself. So I want to review this.
I try to keep it condensed, but I always get sort of sidetracked. DualStim I'm very excited about DualStim. I think it's going to be a great revelation to.
I have one more question, Dr. Gaines, that just came in. So the problem with the question is the focused wave equipment is pretty expensive.
Yes.
So I know we talked about this once before, or a couple times before. A doctor could technically start with one method and move up to the other method. We don't want to discourage people from jumping into this because of cost. There's also some really aggressive finance programs out there, which, once again, we're not covering here. But unfortunately, there's only, and there'll be more, but unfortunately, there's only one FDA-approved, I believe, focused wave manufacturer on the market right now. Unless somebody knows of another one, they can email us. We'd like to talk, I'm not saying we'd like to endorse one, but it'd be nice if there was some competition.
Yeah, I think there are some others, but it is the focused wave is pretty expensive, upwards of $50,000, whereas the radial technology, and that's one of the reasons I really brought it here, is because it ranges between 15 to 19,000.
Oh, and you also think that some of those portable devices may have the cojones. That's a little joke. And then some of those, I believe, are I think we can negotiate under $10,000, and they're still powerful enough. Just so that we could keep the barrier of entry to this market reasonable for physicians, or especially physicians starting out or wanting to try this. I mean, if they had 3 customers, they would break even on that one piece of equipment. So maybe that's the way that people can get into this field.
Absolutely, and you could charge one price for radial, and when you obtain the focused, one price for DualStim. So
that's a great idea.
It can really help a lot of people. It's great technology. By the way,
and don't forget, we didn't cover plantar fasciitis and all these other things to do with the equipment.
I have patients with plantar fasciitis. I inject shoulders. I do a DualStim.
It's also, by the way, it's also FDA approved. So it's FDA approved for plantar fasciitis. So one of the things that a lot of regenerative doctors do not have is FDA-approved procedures or therapies that they can market. That would give them one, right?
Yes, absolutely, and it's it's FDA approved for tennis elbow, plantar fasciitis, temporary increase in blood flow, and for various musculoskeletal aches and pains. So it's FDA approved
like
for
diabetic frozen shoulder. I believe that even some people get insurance reimbursement on that. So
yeah, maybe that I don't know, but
yeah, I don't know for sure either.
It does work on calcium, break up calcium in the shoulder.
Well, everybody, please fill out the registration form if you want more information. We'll also send out an actual copy of the patent. We're taking out the 10 pages of the legal documents in the front. If you really want to read them, send another message and we'll send you those. But the patent itself is 36 pages past that. If you add the 10 legal filing pages, there's 10 pages up front to the U.S. Patent Office, to the attorneys and back and forth. The patent is filed. It's protected, and we are, or Dr. Gaines is waiting on a provisional patent. So right now it is under protection, and that provisional patent should be issued really soon.
Yep. Great. And the IRB for the study, we're going to be doing that too.
Oh, the IRB. So those that are interested in the IRB also fill out just put a little comment in the registration form or email that email that was provided earlier, gainesstore@gmail.com. You will be able to participate in the IRB. You just have to follow the rules, and you will have to, get your site approved and all this other kind of stuff. But that's coming pretty fast, maybe as soon as 30 days. Once again, I'd like to thank everybody for being on the call and Dr. Gaines for your time. Everybody have a great evening, and we look forward to working with everybody on this call that wants to work with Dr. Gaines. Have a great night, everybody. Bye-bye.